actually going to be watching this live. I think most people, by the way, Mark, are going to be watching this months from now.
Yeah.
But this is the first session of Datapalooza, and this is the unofficial Datapalooza stream. We are doing a little bit of coordination with Academy Health, but this is not, they're not endorsing me. I am endorsing them. I really love Academy Health, and I really like that as an organization. And today's session will be sponsored by pillows, because sometimes you need to sit on something soft. Pillows. So thank you for joining us. I'd like to introduce Mark Scrimshire, who works at Onyx Health. Is that right? You're wearing the shirt.
Yes.
So you're doing some automatic marketing for it. Mark is the person that I always call when something about fire confuses me. But unfortunately, is way too much. I find
I can
fire
just
confusing.
confuse you more.
Yeah. So let me say what FHIR is. FHIR, first of all, stands for Fast Health Interoperability
Healthcare
Resource.
Interoperability Resource.
Yeah, I'm very impressed that I know the acronym.
Yeah.
It's spelled FHIR. It's pronounced fire, as in the thing that you start with sticks and grill marshmallows on. And so FHIR is, I think, the protocol that looks like it's going to win the interoperability debate. And of course, Mark and I have both been around long enough to have seen, I think, 3 or 4 other protocols kind of try. I think Direct Project will continue to do kind of point to point. I think it will survive.
Yeah.
But I think the dominant one will become FHIR. Its advantages, as I understand them, are it is web-based, so it's RESTful. It's based on JSON resources and endpoints. So, and it's using kind of the most well-established protocols, OAuth, and I think it uses OpenID. Is that right?
It's OpenID can be used in the identity piece, but OAuth is basically the core in terms of the authorization that is part of what's known as Smart on Fire.
So it looks like this is the thing that's going to win interoperability, and I'm interested in it. I've done some videos on the provider directory stuff. There's FHIR requirements in the provider directory proposals. It's very exciting. I think there's been some announcements very recently about the provider directories, who's going to be doing those things, and if you can bring us up to speed. But anyways, Mark is also a walking gallery member. So before we get going, if you could show your jacket, and kind of to the degree that you feel comfortable. I don't want to. Some people's jacket stories are incredibly personal and not the kind of things they want to share. But to the degree you can, please let me know. What that's about.
I actually have 2 jackets. My other jacket was like number 9. Is you've seen me in my leather jacket. Yeah. It's actually got blue button on the back, and it was one of the first ones painted by Regina. This was painted a couple of years later and was a result of a HIMSS presentation I did. So I was presenting, I think, 2011 at HIMSS, and I was on this conference track, and Regina Benjamin, the then Surgeon General, was the lead off. Regina Holiday then followed, which she's brought the audience to tears, and then this poor schmuck had to go on. And so I did a session on, because I've been really focused around patient engagement, on the AEIOU of patient engagement, and gave that talk. And then a few years later, I was dealing with I was looking at a place in New York for the business I was working with, Media, and went just waiting for a meeting, went down to a shop and saw this Chinese style jacket. And I eventually gave it to Regina and said, can you paint the topic of that talk? Because at that HIMSS talk, that's where my co-founder came, and we met and we formed Media. So that I tend to now wear because it's not as worn out as my original jacket. And it's good to really push the message of patient engagement, patient empowerment. And one of the, if we sort of take that into FHIR, one of the things that Graham Grieve, who's really the father of FHIR, basically invented the whole concept, is he was very much a proponent for the patient empowerment work group within the FHIR community. And FHIR is very much a community that's built up. So it's built on use cases, sort of taking the 80-20 approach to trying to solve things. So you talked about different standards. X12 is sort of enshrined in the HIPAA Act of 1996, which means any financial transaction has to go via X12. And then you've got CDA, CCDA as a XML document format that is still, you're probably familiar with it within the direct context, because typically you'll drop a structured doc into a direct message to send. And FHIR is really sort of taking over from that, because I remember in conversations with the VA about, well, how much data do we put into a document, which is really, when you're talking about someone's patient record, is really sort of a bizarre concept. Whereas FHIR is like, I want to get all the observations, or I want to get this subset of observations, and you make a call for that content.
It's an implicit query.
Yeah. So FHIR is really a structured way of expressing healthcare data, and the REST APIs are a way of interacting with a server that supports that. So it's an exchange protocol.
So Mark, perhaps it would be useful. I think this is a generalized audience. So the reason we're streaming here is because Academy Health and Datapalooza have always been patient-centric conferences, and we are still. I don't know whether we are at the end of a pandemic, in the middle of a pandemic, at the beginning of an endemic, or I'm not sure how to describe our viral situation. But it's not necessarily easy for patients to travel. We're also in the middle of a recession, right? Massive inflation, so not everyone can be here. But we had this long-standing policy at Datapalooza of providing patients and patient engagement. So eventually, I'm going to get to where I can see the comments here. Let me see if I can pull up my LinkedIn page real quick, just to make sure that there are not people who are commenting on this video already. Here we go. Okay, so it doesn't look like there are. If you want to participate in the comments, please go to my LinkedIn. I don't think I'm going to be able to follow, or I don't even think I'm going to try to follow all three of the platforms. I'm certainly not going to be over on YouTube. Maybe Twitter. I might try to pull up Twitter in a bit. But so if you're interested in interacting, please don't hesitate to go ask us questions. We'll try to answer your questions in real time. But one of the things that especially in our conversations together, I think you and I have, we've known each other a decade.
At least, yeah, sort of 2010, Health 2.0, one of the hackathons there.
Something.
Yeah.
And we've probably been working another decade independently on interoperability and healthcare technology. And so when we have conversations, first of all, it's always good to see an old friend. Somebody's like-minded. We are both healthcare meme compliant. I just wanted to point out, I've got my jacket here. Here's my jacket, and I'm trying to get some things to show it. This is my Turn the World Upside Down jacket. I have my other walking gallery jacket, but and then the other meme is pink socks, and we're both wearing our pink socks.
Yeah.
So we're both very much trying to at least be involved in and connecting with patients in the patient community, and that's the point of this stream. So if you are able to interact, and if you're watching this and you don't understand what we're talking about, please ask. But I'm going to try to empathize with the audience, especially because the main reason that I have these videos is so that patients in the future can go back and look them up. And so we're going to leave these resources up. And so I want to make sure that we kind of explicate things. So first of all, Regina Holiday is an artist activist.
Yeah.
Was very famous, worked in DC, did some murals, and got on the fastest person to get on the cover of the British Medical Journal.
Could be.
Something like that. Anyways, and she's continues to be very successful. She's moved. She's now a minister.
Out in Western Maryland.
That's right. And so we even every year she does a patient conference, and so we do see her, which is lovely. But she started the idea of a walking gallery. And the idea of the walking gallery is that patients would be going, 10 years ago, 15 years ago, a patient would go to a cardiology conference, they were a cardiology patient. Not only would they not be acknowledged, they'd go to a whole conference, and you'd be hear people talking about, cracking ribs and talking about the ventricles and all that kind of stuff, and never mention the fact that these were in a person.
Yeah.
And so there was very much a disconnection between the patient community and the clinical community. And part of the way that that we started kind of breaking down those barriers was that patients and people who represented patients or wanted to advocate for patients would write their patient story and ask for an artist, starting with Regina. Regina has painted hundreds at this point.
There's probably about 600,
maybe
plus.
even 1,000 soon.
Yeah.
Jackets that are essentially intended to start conversations, because they're so startling to have somebody obviously wearing art on their back that you're supposed to say, well, what is that about? And then people will tell you to this kind of general premise, which is it's a way to bring patient stories into conferences and clinical conferences, but then also your particular story, like what brings you here. And so, so in general, when you see someone with a jacket, you can know that they're kind of with it. And what I consider to be with, there's very much an in crowd of people who really, really passionately care about really changing things in healthcare. And eventually I see them get jackets. There's a bunch of people, of course, I know who don't have jackets who are still passionate.
Really should. Yes.
But definitely is that if you're willing to skyline yourself that way, it's almost always because you really care a lot. So,
well, it's great when you go to conference and you actually see other folks, because like you say, the patient tends to be underrepresented, and everybody I think that's got a jacket is some way trying to drive making it better for patients. And so that is a way that you can recognize people of a like mind at some of these big conferences.
Well, what I think is fascinating is it can be a like mind, but very divergent professional background. So I'm not a clinician, but a physician might wear one, and you'll see researchers wearing them. And so you know that you probably should go talk to that person. It's a wonderful thing. I think pink socks is pretty similar. And I've already done a whole video on pink socks. So I did that yesterday. So please go listen to that. We did have the pink socks meetup last night. So that's some of the context of what Mark is talking about. And then let's see. So OAuth is a protocol for doing authorization. It is the kind of standard way for one application controlled by a developer to interact with some kind of a central resource. So people know it by, like, I think Twitter use OAuth.
Let's put it in really simple terms, right?
Please do.
If you've got your phone and you want to share your cat videos on Facebook or Twitter, you're going to connect your app. You're going to download an app. You'll go through a step where it says log in, right? And you'll log into Facebook from within the app, and then you'll say, yes, I want to share my videos, to Facebook, and you'll basically authorize that sharing. That's basically the handshake that OAuth is doing. What's happened with Fire is there's two or three parts to it. There's a definition of the data that you want to exchange. So if we want to share a patient record, right? Traditionally, you've probably grabbed a CSV file with a bunch of patient information. And the first thing you have to do is work out, well, what does each field mean, right? Whereas Fire, what it says is, this is what a patient record will look like, and this is the data that it can or it must contain. So as a developer, you spend less time working out what the data is and more what you want to do with the data. And so then OAuth is just, which is wrapped into the Smart on Fire protocol, is just that mechanism of being able to get to a position where you can actually get to the data, because it needs to be secure. Okay. So it's the healthcare equivalent of an app talking to Facebook. Right?
Well, and I think that what's really interesting is for years there were attempts to do this kind of work not using standard web technologies. And so part of what Fire represents is a concession in the health IT community that general internet protocols for sharing data and doing authorization were kind of rock solid and needed to be the center of.
And one of the key differences is that HL7's Fire is effectively open source. So unlike X12 and other standards, you don't have to go and spend an awful lot of money to get your hands on the actual specs. I describe if you go to HL7, you go to if you just search for Fire online.
Let's do it.
just do like fire US core, and
US core.
You'll pull up one of the implementation guides that they talk about, right? And I describe everything there is basically a wiki. So that the publishing standard for these specifications basically creates a wiki, and Fire is like the text version of YouTube. You get into it and you can spend hours linking from page to page to page.
So I'm part of the reason to talk to you. Part of the reason I like talking to you. Just so you can see, this is what's on the stream right now, right?
Yes,
this is we're on the one side, and then this Fire page is in the middle, and this Fire page is a perfect example of what I do find intimidating about Fire. It is I think you're talking about X12, and X12 is is what's known as an EDI standard, as electronic data interchange. Yeah. It's very, very dense. It was made for the era of 400 baud modems. Where you could hear the digits going across and things like this. It's really and it's super, super compact and dense. And I think actually dates back to the Berlin airlift in the days of EDI, or at least that's what the internet says, and I'm inclined to believe it, just because it is so it's so dense. But JSON is, I think, the second generation, XML being the first generation of human readable data interchange standards that were inspired by HTML, which was a kind of focused way, but it was human readable. You could look at HTML code and read it and see what it said. JSON is the same way. It's the latest generation of that kind of idea. It's a little more compact than XML, but this Fire page from HL7. The problem that Mark was saying is that you can't get access to this underlying complexity protocol stuff. You have exactly the opposite problem with Fire, is that they give it all to you, right? Exactly. It's all right there. Everything's
every
right
version
there.
Of the Fire specification itself is now, they're working on Fire Release 6, right? The industry is really, in the US, has really gravitated around Fire Release 4. But every single version of these specifications and the implementation guides are available online. So you can, it
looks like, Mark, that they're literally all linked to from that webpage right there.
You will ultimately be able to get, because you'll be able to go to, if you do a simple thing like, one of the first things I end up doing is going and looking at the directory of published versions.
Okay,
right?
There you go. All right.
So this is going to tell me every version, and every one of these I can click on a link and see what was in that version of the spec. So, for example, a version of the spec may be produced for a connectathon event where they're going to test certain things. So you can sort of freeze it. And then there's a whole publishing process around publishing these guides. As a developer, once you've seen one of the, it may be intimidating when you start, but once you've seen one of them, you'll get used to that. There's going to be certain things that are in every version
I see.
of the
so
guide.
You'll see kind of the consistency.
Yes. So if we go back to this, so this is telling us, where do I find it officially on the web? This is a balloted version, so it's going through the publishing process. It's got other things, and then you'll see in the top bar, okay, you can download this as a zip file and have the whole thing there on your laptop.
So useful to have zip files.
And here's here's your various artifacts. So here are the profiles, and here's the capability statement. So what's that? Capability statement is just typically a JSON or an XML document that basically says, I'll try and keep it simple. When you hit a Fire server and you go to sort of the base or / metadata, it'll have a description of all of the types of records, profiles that that particular instance supports.
So let me ask you more about that in 1 second. I just want to point out that Alan Byers is chatting to us on LinkedIn. And
hey, Alan,
this is one of these situations where you just can't keep the riffraff out.
I know.
You're streaming, and anyone can come in and ask questions and look at stuff. We we can't really help that. I also see Ashish Patel, my business partner over at CareSet. So thanks for being there. Could X12 be replaced or displaced by fire? I think the answer is could, and it would be the far future. I think there are efforts specifically to do that. So there are people who are working on that now, but I don't think it's the kind of thing that it's not going to be soon, and it's not going to be easy. But maybe.
First, you have to prove that the standard that you are proposing to replace X12 is actually fit for the purpose, right? Because those standards of X12 is basically enshrined in the HIPAA Act of 1996.
Well, I mean, it's not. It's kind of right. So the Act gives the power to CMS.
Yes,
CMS has an ongoing power to regulate about what they choose. They can choose to do something else.
Yeah,
but they can't do that willy-nilly.
Yes.
Right. It has to.
So they have to go through the whole process of going through it.
By the way, for those who are curious and idiosyncratic and interested in this kind of inside baseball, that same act is what allows what makes CPT codes.
Yeah.
Endorses CPT codes. Endorses ICD as the diagnosis protocols. I think almost every aspect of modern claims is dictated by that. I can't remember what version of HIPAA it was, but there's a privacy rule, there's a security rule, and then there's the kind of all the other things rule.
Yeah.
And the all the other things rule ends up having, in some cases, a lot more impact than everything else. And I just wanted to point out for the stream, I'm just kidding about Alan Byers. He's a dear friend.
Yes.
And I really appreciate his work, and he's contributed a tremendous amount to FIRE and dozens of other really critical.
Yeah. Well, we met, Alan and I were doing a hackathon together back in San Francisco in 2011.
Right. I think that might be, if not where we met, an early interaction.
Yeah.
So I have a huge amount of effect for Alan Byers. And Alan, if you have anything else you'd like us to give some shout outs to here on the stream, please go ahead and type that in, and we'll do that for you.
So to your question about X12, I've talked to folks in the standards organization at CMS. I spent 5 years there working on Blue Button, and they said, well, why can't
Remind me to explain what Blue Button is after you're done.
And I was asked the question, why don't we make the change? And it really is the case of you've got to prove that this can work at scale, which is what X12 does.
It's absolutely
it drives every financial transaction in US healthcare has to go via X12. So how are you going to take a standard like FIRE and get it to that volume that it can deal with? And that's really the work that's going on at the moment that CMS is supporting around initiatives like the FAST accelerator in HL7, which is around putting some of the basics that you need, like how do you find an endpoint that supports FIRE? You need a directory, right? A lot of the things I've been working on in the Da Vinci project, another one of the accelerators, is if you want to implement payer data exchange, one of the things I've been working on, you've got to be able to find the other payer and know how to connect to them. And that needs effectively a discovery service, so basically a directory. And that's one of the elements in FIRE. You've also got initiatives like TEFCA, which ONC is promoting to create this sort of national network.
And TEFCA, by the way, so when you work to let's say you're a hospital A, and hospital A is the big hospital in the city. Hospital B chain is the second one, and they want to exchange data. In the past, what they'd have to do is they'd have to come together and they'd have to write from scratch first of all, a business associates agreement, which indicates that they would protect each other's data in general. And then underneath that, they'd have to say, well, this is exactly what we're going to exchange, and this is how you're going to protect it, and this is what the standards are. And I believe the standards, it's TEFCA, is that the right one pronouncing?
Yeah.
Is an effort by ONC to kind of standardize that. And it's not the first one, but it does seem like it's got the one with the most chance of kind of becoming.
It's getting legs. They've just announced, like last week, the first round of what they call QHINs, which is sort of the top level network. So again, a lot of it sort of builds on a lot of the theories and practices that have been implemented in the internet.
Right.
Where you've got your top level domain names and then you've got
down.
Yeah. So
before we go on, speaking of kind of precedent, so we are, and FIRE is trying to essentially do things in the internet way, and it's surprising how that has not happened before in health information exchange protocols. So rough consensus, working code, a lot of those kind of general ideas about how things should progress. But there are precedents in healthcare that are pretty valuable, especially in terms of attitude and principles about how things should should happen. Tell me what Blue Button is and why that's important. You've mentioned it a couple times, and I just want to make sure people understand that.
Well, we sort of first met when Alan and I were hacking on this hackathon, taking a text file that was known as Blue Button. It was originated at the VA and CMS back in sort of 2010, 2011. And it was a way that patients could download their data. So basically CMS, you could go and download 3 years worth of claims information. But you ended up with like 1,700 pages of text, and you can't really do much with that. People did, but our hackathon attempt was saying, how could we anonymize that data and reshare it? It was a simple idea. But the net of that is I eventually got asked to go into the US Department of Health and Human Services, into their idea lab. I was an entrepreneur in residence, and I was assigned to CMS, and they basically wanted to do Blue Button 2.0. They wanted to go from that text file to some sort of structured API, and to make the data more easily available, more easily usable. And at that time, it was about 2015, FHIR was just sort of bubbling up, and there was the Argonaut project that people like Anish Chopra was promoting. So you had the big EMRs started to say, well, yeah, we can publish a standard set of data formats. And that was built on FHIR, and me being a bit lazy, it was like, why invent your own API when there's something out there that you can build on? And so at CMS, I basically designed the platform for Blue Button 2, which today has something like about 57 million Medicare beneficiaries, fee-for-service data. And there's now something like 7 years worth of data published for those members if they want it, and they can connect an app of their choice into that using FHIR APIs. So we worked with the FHIR community to define the explanation of benefit profile, which is just a mechanism to put what it can be a complex claim into a format that could be downloaded by an application developer and interpreted. So you've got a patient record, a coverage record, and a claim, an EOB as we call it. And that eventually got published. Well, when I went through the process to get the APIs published at CMS, I followed precedents that were out there. So the original Blue Button was publishing 3 years worth of data. So we're going to publish 3 years worth of data. The thing I forgot to tell them is that we weren't going to throw any of it away. And so every year it got to be more and more. So Blue Button really became the model for the CMS interoperability rule, the interoperability and patient access rule of 2020, which basically CMS turned around to all of the payers that they regulate and said, yeah, follow our lead. You can do this, and set out the regs to require that. And it was basically taking the then current standards like US Core, like HL7's Da Vinci project, which is a group of payers and providers, agreed on how to do provider directory. So as a health plan, I could publish a standard API for all of my providers.
Sorry, I'm scheduling. Keep going.
And there was also a formulary as well. So there was and then Karen Blue Button is an implementation guide modeled on what we did at CMS that takes the claims information and coverage information and publishes that. So now the patient access API, as we refer to it, is claims, clinical, provider directory, although that's an open API, you don't have to log in to use it, and drug formulary.
So let me pause you again. So I just wanted to kind of say I want to thank Erin Moore, who's going to be helping me kind of wrangle speakers, and I'm going to be texting her. So I'm going to be looking like I'm rude to every guest while I'm on my phone, but it's because I'm trying to sort out how to get the next person on. And so forgive me for that. Forgive me, Mark. I'm going to make that apology again throughout the day. Let me, if you don't mind, roll back. And these are the kind of things that you can only see in clarity in retrospect. before Blue Button happened, so there was I can't remember who it was, but I think it was a politician or it was a political advisor. Somebody said, "Why can't we just have a blue button that lets you, a little blue button on an interface?" Let you download?
Exactly. That was Blue Button 1.
And so Blue Button 1 was, I think this was a really kind of revolutionary idea, because what they decided to do is before this, technically, under HIPAA, you as a patient had the right to request your data. Get it? What that would mean is you would go to your doctor and you request this, and 3 months later, roughly, you'd get a CD-ROM that they would burn for you that would have this data on it, which would be totally inaccessible. So they started asking, why can't we just download this? Why can't this be easy to download? And of course, there's a chicken or egg problem, which is if you just allow people to download what's there, then that's not useful. They don't have any way to process that. But if you can't download it, then nobody can write code to make that do useful things. And Blue Button was a really kind of decide, we're going to start somewhere. And what we're going to do is we're going to literally have a blue button and it's going to download stuff. And I think the history on this, and this is the version that Alan and he were originally working from, was very much something that I think the VA started.
VA was the first implementation.
VA was the first, and at the time, and even now, still, they're moving to a new EHR. But the VA Vista was the underlying architecture, and so what they did, it was, what is easy to export from VA Vista? Well, this is, and they pressed export button, and it kind of comes out of this kind of text dump, and that was what the Blue Button data standard was what was available. But that was revolutionary at the time.
It was, but one of the key things there was really this idea of, well, you're putting together a patient portal typically. So I, as a member or a patient, can at least log in and see some data. And so the revolutionary idea was, well, if you've already let me see the data, why can't I just hit and download it in
some kind of digital form?
Yeah.
And of course, it's very much a chicken and egg problem, and it's similar to like, okay, well, we want to have hydrogen cars. Well, we have to have hydrogen gas stations where we have hydrogen cars. You can't have hydrogen cars because you can't have gas stations. You can't have the cars because you don't have the gas stations. You're just in this loop where something has to go first. And I think solar and electric cars are in the same thing. You have to start.
Yep.
And Blue Button was a start, and then very rapidly, what happened was, well, people learned to use that kind of version of the VA data dump, and then like, oh, let's improve what that data looks like, and now let's make it standards based. And now, of course, we're talking about, well, you're going to authenticate with that data using an open standard. You're going to download it in an open standard, but the revolutionary idea of, we need to make this easy. It has to be in the native format, and it's just like, give us what you got. Blue Button was an amazing idea, and so I just thank you for your work on that.
What's really has been interesting is when CMS put out that interoperability rule. For example, it covers Medicare Advantage, CHIP, so Children's Health Insurance, but it also covers Medicaid and the qualified health plans, but basically the market in the federal marketplace. The interesting one is Medicaid, and it's something we've been really focused on at Onyx, is that still today.
By the way, we're gonna start advertising a little bit for your company here. So this is Onyx. This is a document which you can go and register and get this, and I recommend that people do. If you're interested in this, you can get their Advancing Interoperability and Empowering Prior Authorization.
Let me give you a bit of context on this.
Please do.
So back in December 22, CMS put out a proposed rule which everybody's been waiting for like 2 years, around prior authorization. This, I know it's a subject close to your heart as well, where you have this process of, am I going to get approved to do this procedure for a patient, and am I going to get paid, right? Is really answering that question up front. But the way that happens today is that if I'm the provider or my admin, they have to know, do I need to get on the phone, or do I need to send a fax, or do I have to go to a provider portal? And then when I've done that for any one of 20 different health plans, which procedures actually require a prior auth or not, and that can vary from plan to plan. So what CMS has basically done is saying, let's have a standards-based way of making that query, and then determining what, if I have to give you a prior auth, what data do I need to give you to make a decision? And then the third part of it is, well, if you've made the decision, or you are in the process of making that decision, tell me about it in a standards way. Where do things stand?
Which,
right?
by the
So-
way, I mean, he's talking about something that X12 does. So most
Yeah.
people only do the payment request, but there's also a payment status,
Yeah.
and there's all kinds of things in X12
But-
that help with these kinds of things.
But this question of do I need a prior auth is the X12 standard is really dealing with, yes, you need a prior auth, send me the stuff, right? And then you've got the question of how do you put all the supporting data to go with that? So this rule that CMS put out, really the second one that builds on the interoperability and patient access rule that Blue Button was really the model for, is really trying to address some of those problems. And it's actually expanding on the original interoperability rules. So CMS is doubling down on the APIs.
No, I mean, well, I certainly think that it's true that they're doubling down on the APIs. And could you explain, and this is, at a worst case, I will be able to go watch these videos again and look up what you're saying. So there's a kind of ladder and ratcheting function where ONC and CMS and HL7 are kind of ratcheting forward what is available under FHIR, what FHIR is trying to do. And there's kind of one ratchet that is what the standard is, and there's another ratchet of what is required in EHRs, and there's another one that's about what is required for payers. Could you explain what you understand about that?
Yeah, and probably not the expert on this, but I'll give it a shot. So what you've got is ONC is really setting a series of standards.
Office of National Coordinator.
Office of National Coordinator for Health IT. So that's where Mickey Tripathi is now, the ONC coordinator. Yeah. And they have a process where they're working on what they call USCDI. So it's basically the core data for interoperability. So they define this is the set of data that ought to be exchangeable, right? And so we have USCDI version 1, and there's now like 3 versions in various stages.
And to be clear, they certify an EHR.
They have a certified
Medicare says, CMS says, unless, I think it's now like the days of you getting paid extra are over for using a certified EHR. But if you do not use a certified EHR now, you get paid less by Medicare. So CMS is requiring the marketplace to purchase EHRs that are certified by ONC standards. Right? Am I reflecting that correctly?
Yes, pretty well. So what's happened now is ONC recently released what they call their G10 certification. So what they've done is originally the APIs that were being supported by EMRs were on basically a 6 or 7 year old version of FHIR, what we call DSTU2. So a limited first version of US core. So what happens is USCDI is sort of, I described it as sort of the semantic description of the data that ought to be exchanged. And then the FHIR community comes along and there's a group, US Realm, that creates this US core specification. And that US core specification tends to be the structured data instantiation of USCDI, right? So you'll have USCDI version 1, where the equivalent is US core 3.1.1.
Well, that's helpful and clear.
Right, okay. Yeah, sorry, I live and breathe this stuff, right?
Yeah. So the important thing is there is an equivalent version.
But the beauty of this now is that any EMR that wants to be on that certified product list for the ONC, I'm seriously selling an EMR, needs to now support by that G10 certification.
Come on in.
The US core 311.
What do you think? I think that was for us. I'm going to go open the door. Carry on.
So what it means is that every EMR is handling the standard set of profiles. So whether it's a patient record, whether it's a condition resource, an observation resource, they all will be complying with this same standard.
I see.
And because FHIR is a RESTful API, you can query those resources, and the specification defines what search parameters are supported. So now you're reaching a point where every EMR out there that's worth its salt, you can query in exactly the same way for a certain standard set of resources. That set aside the question of can I get connected, but now you've created this level playing field that's a known quantity that you can, as a developer, program against.
So, I advise lots of health IT startups, and some of that is, hey, you buy me lunch advising, and some of that is, they're actually paying me to come in and do something more serious. And almost invariably, I have recommended for years, like, you want data with EHRs, and you want to, if what you want to do requires you to get data from EHRs, get a new business model. And that's been, I think, unfortunately, pretty good advice, because and then there was a brief period of time there where you could do interesting things with the proprietary APIs. Athena Health had a really good one. Allscripts had a really good one. And I think they still do, of course. But now I think those APIs are starting to be kind of universally accessible. So theoretically, you can have a business model today, and I don't know that it is fully sustainable yet, where you can say, I can think of an app that operates in this manner. But you can access the EHR data of patients, and you can have an app that is in an Apple store or a web page or in a Google app, and you can make a business by leveraging these APIs. How close do you think we are to that?
We're pretty close. There's a couple of things that are happening there. If your business model is built around providing, getting data for a single patient, being able to present that to them in certain ways, then that is sustainable. The question there is, ultimately who pays, right? And one of the things I've suggested to folks at CMS is saying, why can't, if you look at health plans today, you typically get a free annual checkup. That's part of the Affordable Care Act. Well, what would happen if you could actually recover the cost you spend on a subscription to an app of your choice? So like $10 a month, because then what that would do is, as a patient, I cease to be the product and I become the customer. And it also gets the payers and the government out of deciding to pick the winners and losers of which apps are we going to recommend, right? Let the market win. It's perfectly doable if we could get a code for subscription to a digital app, right? It just requires us to think a little outside the box. But
so before we go on, let me just say what Mark means when he says, if we could get a code. So there's two ways to get codes. And what he's talking about is a remuneration code, which is either going to be a HCPCS code, which is something that CMS will come out and say, we are going to pay for X. And almost always that is kind of a commentary on the other source of codes, which is the American Medical Association CPT codes. And in general, CPT codes, if someone invents a new way to do foot surgery, for instance, they get a new CPT code for that. And so when you say get a code, it's really parlance for a formal approval by the healthcare system as a whole that something can be remunerated financially.
Exactly.
And I, by the way, to the viewers, I apologize. We are both trying to go back and kind of backfill the vocabulary that is necessary to discuss these things. I think we're doing an okay job, but listen, if you want us to say something or explain something, and in fact, if you're watching this and you're confused, and I see your, actually now I'm looking at Alan's got some more stuff. So I'm going to just read what Alan has said in a second, but let me put this. I'll put Alan's comments up front, so we'll remember to do that. But in general, if we're talking over people's heads and we're talking an acronym soup, which is it's
so easy to do.
It's very, very easy to do, because there's exciting news. I mean, there's things that have happened in the last 6 months, even the last month, that are big news in this space and really important areas to discuss. Please help us out by complaining, and we will try to sort ourselves on this.
To your point about the business model, if you're trying to access data for a single patient, the mechanisms are there to get
Right.
that data
Okay.
out of the EMR and now also out of payers.
Oh, interesting.
That's what the interoperability and patient access rule did. That's what we at Onyx have done. Is when Seema Verma announced Blue Button to the world in 2018, we could see the writing on the wall that plans were going to have to go and do the same thing.
Right.
So we set about building that platform for payers. As we built a FHIR interoperability platform, and one solution on top of that is the patient access API. So it provides a mechanism for payers to get their data converted from whatever custom formats they've got into these standard FHIR formats, and then allow the member's identity, user ID and password they use for their member portal at the plan, to be able to come in and authorize the sharing of their data with an application,
so that they can be an OAuth endpoint.
So the plan now has an OAuth endpoint that can share FHIR data. That's what we build. We provide that to a whole bunch of payers. Interestingly, Medicaid in many cases is way behind the curve, and it's understandable. We've had a pandemic for like 3 years, but also Medicaid often has a problem in that they don't actually have an identity service that gives a beneficiary an identity.
Yeah.
And if you do not have an identity, you can't authorize the sharing of anything.
Yeah.
So what we've done is put together that solution. We've now got it in 3 states.
Oh, that's brilliant. So congratulations.
Yeah.
To you and to them.
Yeah. I mean, Maryland, Connecticut, and Idaho.
Nice.
Currently, we've partnered with ID.me so that anybody can go and get a digital account, and we can do the matching to the FHIR data that the Medicaid agency has published. And that now a consumer app can come and register on our developer portal and basically go and start marketing to consumers to say, we've got the app, come, give us your data, then we can help you. And it's really still early days. And I say now the challenge is, where's the business model for these apps? Because yes, they're not having to pay for access to that data, but where do they make the money? Because the consumer's typically not going to pay. So is it the health plan? So how do you get approved by the health plan in some sort of business relationship? That's why I go back to, why can't there be a way for me to put on either on my taxes or on my health plan, I'm subscribed to this app, and get that remunerated, right? So I'm maybe paying $10 a month. The app is now getting revenue, and it makes me the customer, not they're taking my data and they're selling it in all sorts of nefarious ways.
So first of all, it's super exciting that you guys are doing stuff. It's great news for you, for your company, and just in general. It's amazing that Medicaid beneficiaries are getting these benefits. It's really, really important. So congratulations. I think but I think what you're describing is a shift, and there's a classic business plan in health IT companies that essentially are seeking to have payers pay for them, which is the alternative to getting a code, which is a per member per month phenomenon. And what you're describing is a way to even circumvent that, and to say we want to have something that is yes, it's remunerated by the payers, but it is something that, rather than having a partnership, a deal behind closed doors about what gets offered to patients, instead you move it into a code, you move it into something that's remunerable, and as a result, it creates a marketplace effect, and then the best players in terms of who serves the patient best, who's got the best user experience, which are things that, let's be honest, have been really severely lacking in healthcare IT offerings when they face the patient. They're better when the doctors will pay, and the hospitals will pay, and the payers will pay. So they get better user experiences, and then what the patient experiences is usually pretty terrible, right, in terms of quality. So talk to me a little bit. I just want to, I think we're almost winding up. I want to let you get back to the conference and maybe see a keynote or two, but what do you see as the coming things? What's coming for you, and what's coming for?
So at the moment, there's a few initiatives going on. The No Surprises Act was published a year or so ago, and out of that is an initiative about patient cost transparency. So if you're going to go in for a procedure, you want to know what it's going to cost and not suddenly get a bill from the anaesthetist that was out of network and now you're in medical debt up to your eyeballs, right? So there's this move to have what they call patient cost transparency. So it builds on the price transparency where plans and hospitals have had to publish their most popular procedure prices. This is, I'm going to get this procedure, the provider's going to effectively put together an estimate and get it agreed with the health plan and be able to share that with the patient. So, you know, this is what's going to get covered by your insurance and this is what you're going to have to pay, and there's going to be no other surprises. So we've actually built a patient cost transparency tool that can be used by providers to work with plans. So think about, you want to go typically to providers that are in network, you get better rates and so forth. It's more likely to be covered by the health plan. So we've built a product that helps that whole process of getting that estimate, because provider doesn't work on their own. Are you going in for an operation? You've got the hospital, you've got the anaesthetist, you've got a whole host of team that is delivering that ultimate service, and it's a case of pulling all of that together into one estimate. So we've built a product for that. But the big thing is, and if folks download the ebook that you kindly demonstrated, we're building and have built and tested parts of this prior authorization rule that CMS is proposing. And so there's a few key parts to that. I say it really does a couple of things. One is CMS has very clearly stated FHIR release 4 is the standard. But within that, they're not actually mandating specific, in FHIR parlance, implementation guides, because the implementation guides improve, they iterate, we get new versions, and the industry is still in a state where those things are still maturing. So you don't want to create a cast iron standard that you're then stuck with for 30 years.
Which is what happened with S12.
So they're recommending a series of implementation guides. So they're very clearly saying, go to these guides that have been produced by the HL7 Da Vinci Accelerator project. So to your earlier question, you know, what's happening about what's HL7 doing, what's CMS doing, what's ONC doing? CMS has been in discussions with Da Vinci for a long time. So Da Vinci, as an accelerator project, says we should be producing these types of implementation guides because we can see that CMS is interested in being able to regulate about this, but they can't regulate if they can't point to a standard, right? So by creating the implementation guides, they create something that CMS can say, you can comply with the standard by doing something that way, but not actually saying that's your only option, right? So, but it's
fascinating because, of course, you know, the way industry standards work is it really is your only option, because the whole point is to do interoperability.
Yes, exactly.
And so what I think is good is that this is a chicken or egg problem, and the regulators are limited in what they can do. They cannot say to a market, they cannot dictate to a marketplace about how a marketplace should operate. So there's limitations on what regulation can do, but at the same time, the marketplace in healthcare has been resistant to interoperability generally. And so this is a good balance of the rules and the interests.
So CMS has made it, you know, must be about 5 years ago, basically made a clear indication that they were moving away from fee-for-service to value-based care. And so that's where providers and payers are sharing risks and rewards. Well, when you do that, now there's a need to share information, because if you're carrying risk, you need information to be able to make sensible decisions. So it's encouraging interoperability, because at the end of the day, does it mean I can get paid better because I've got more data, I can manage my patient population more effectively, they're healthier, I get higher star ratings from CMS, so I get paid more money. And hey, I'll share that with you, Mr. Provider, if you help me do that.
Yeah.
So this is what, so you've got that driver coming in to say, there's a reason to do interoperability. And now it's, well, there's no point doing interoperability where every time I connect with a new provider, I've got to build a new interface. So what HL7 with FHIR has really done is saying, we're using these standard set of standards, we're using these, the resources we're talking about are going to have this type of data in it. And there are going to be these mechanisms for exchanging data in different ways. So the prior authorization rule, if we quickly recap that, has got an expansion of patient access API. What they're doing is saying, okay, today as a member, you can log into your health plan if you're with like Medicare Advantage, and you can get any clinical data they manage, any of the claims data, you can get at your drug formulary, and then without any login, you can see the provider directory. Prior authorization is saying, okay, we're going to make that same set of data available to some different audiences, but we're also going to take the prior authorization data that comes out of those prior authorization decisions and make that available to the patient as well. So they're adding into the patient access API. So now, before long, well, 2026, if it goes, you will be able to go and get those prior authorizations.
Which, I mean, I sigh when I say that, but that's so fast.
But it is fast, and we need to still build some of the standards.
Yeah.
Right.
Yeah.
So what they're also saying is, we also want, if you move from plan to plan, which we do, you know,
does happen.
You move from one Medicare Advantage plan to another, or your employer moves you, although they're not covered by this rule right now. They're saying there's going to be a payer-to-payer API. It's what I've been working right in the spec on for the last year or two. And that will mean that when I go to a new plan, I will be able to say to the plan, go get my data from my old plan. And the plan will go take your information plus your consent, pass that to the old plan and say, do you recognize this member who used to be in your plan? They want me to get their data, and you'll be able to do a match and pull all of that history. So now you're building the longitudinal record can move with you, right? So that will include all of that data in the patient access API, less the financial information in the claims, right?
Okay.
So, but it will have the prior authorizations, including the refusals.
Oh, that's interesting.
So for up to a year after a refusal, it will be in the record. The prior auth will also show the status of the progress to getting a prior auth. So as soon as it's registered, it will be available to a member. The decision will be noted, and the consumption of the prior auth will be tracked.
Oh, that's very interesting.
Right?
That's brilliant.
And that will go when you move from one plan to another.
Yeah.
The plan would be able to, they're not forced to go and look at that information. It's going to be available to you, but they could go and look and say, oh, they've got a prior auth for this set of things. Maybe I should be putting them onto this plan rather than wait for them to turn up in the emergency room because they can't have access to their meds or
whatever
oxygen or whatever it is.
Yeah.
Right.
Oh, that's fascinating.
And then the other piece that's added into the prior auth rule is saying providers will be able to effectively declare a treatment relationship with a patient, with a member, and be able to go to the plan and say, tell me what you know about my patients, and do a bulk exchange of data. So now the beauty is the plans have a very broad but not necessarily deep view of your health situation. I call the plan, the health data at the plan is like the connective tissue of your care journey, whereas the provider is very deep but very narrow. And so this provides the opportunity for the provider to understand maybe where you've been snowbirding in Florida and now you're back in Minnesota,
or just to know that you have a cardiologist.
So
it sounds like that's the kind of thing that a primary care provider would know, but it's not.
So they're providing that ability to get that same set of data into a different set of hands.
Oh, that's fascinating.
Right? And then the prior authorization core rule itself is really saying, instead of having to know whether I have to get on the phone, get on a fax, or get on a provider
There's
portal,
always a place to go.
here's a standard way I can say, does this thing require a prior auth? And then it's going to say, if it does, this is the data that we need out of your EHR
in order to make
the decision.
Okay.
So it should speed up the process, because instead of bouncing backwards and forwards saying, well, you gave me this, but now I need this. Now it'll be said, okay, send us this block of data and we can make the determination. And it's not really changing the prior authorization process and that investment that payers have made to date. That process of deciding can still be the same. But when they've made the decision, there's going to be a FHIR standard profile that says this is the detail of the decision.
So I need to go sort out what's going on.
Yep.
And it looks like we're not going to get Dr. Califf, which is figures we didn't confirm him up front, and that's unfortunate. Having said that, I'm so glad that I was able to open my stream with this conversation. It's fascinating. I'd like you to say how to get a hold of you personally, how to follow you online. You have a Twitter account?
Yes. So eKiveMark, EKIVEMARK, eKiveMark. You can also just go to my company, onyxhealth.io. So Onyx.
Yeah.
Health.io.
And we showed the URL earlier, so you can go back and look at that, and you should be able to see the website.
And you can find me on LinkedIn as well.
I was going to say, I mean, it used to be Twitter was reasonable enough that wasn't a good enough thing to say, but so you are findable on LinkedIn.
Yep.
And I think I can reply to my own stream and put the comments and put your profile in the comments, and I'll try to do that. Alan, I'd like to thank you for making some questions. And just real quick, Alan said, for provider data, in my opinion, FHIR is not well suited for the purpose. I've been looking at an identity standard SCIM as a model for represent provider data. I have no idea whether Alan is right about that, but I do think it's important. What do you think?
I think there's a lot going on in this space. So CMS put out an RFI at the end of last year around whether they should have a national directory, but it's not just a national directory for providers. We need a national directory that includes endpoints, various other healthcare service providers. It needs to be that discovery mechanism that we can get connected digitally, programmatically.
Yeah.
Rather than.
And Alan has another comment here about OEIDs and how things should work for provider directory. And I would just encourage you, if you're watching this video, that you should scroll down and look at what Alan has posted. I don't always end up agreeing with Alan's perspective on things, but most of the time I do. And so, and more importantly, I think I've never had a case where, even when I disagree with Alan, where Alan's positions weren't really well informed. I mean, he's really short.
Oh yeah.
So, so please do pay attention to Alan's comments. Thank you for commenting, Alan. I really appreciate it. Thank you for watching. Mark, thank you for being here. I really appreciate it. Thank you. I think that's going to be the first chapter of our live stream. So I'm going to pause and take a break. Thank you for joining, audience, and thank you for watching. If you're watching it 5 years from now, or whatever, see you later.
See you, folks.
All right. So how do I turn this off?